So, welcome to my weekend before the HESI review. You've all gone through pediatric nursing, whichever level it's on. It's the same concepts, and we're going to be talking about them. And when you see certain things, what do you need to think about? What should come to mind? What are those key words like, oh, I can figure it out because I know those things. And hopefully after I do this review, I might be picking on a couple of you saying, what do you think? What do you think? Don't be embarrassed. Please don't be embarrassed. Nobody knows everything. I don't know everything. And I've been doing this a long time. So if you have a question, please stop me. I'm sure somebody else is going to have the same question, but they were too timid to ask. Remember, as nurses, when you get in the field, what's going to happen? You're going to have each other. Right? So make sure you talk with each other and you help each other, because if you think you know everything, I don't want you to be my nurse. I want that new nurse who asks questions about everything. Okay? I know you. So, just to let you know, nursing is a we, it's not an I. So, please have questions, let me know. So let me share the screen and let's go right to the nursing Q&A. Now, how did I get this thing? Where did it come from? That's the question. Well, every single end of the quarter, I have to do a report. And the report looks at, I've never seen a question. I don't know HESI. I don't know what's on it. All I know is it might say a question, intussusception, S&S, signs and symptoms. That's all I get. So I can figure out sort of what it could be. Or Pavlik harness. What do I know about that? So I'm not given a lot of information. But through the years of me doing this, I have narrowed it down to concepts that I see repeatedly. And after every quarter, like this break, I'm going to be doing another, what we call a HESI analysis, all right? And looking at those questions that you didn't do well and those questions, the concepts. What is it on? Is it on infection control, safety? All of those things I look at. Now, after all of that, I went down and wrote down concepts. And I didn't do from one HESI, I did it many. And from that, what I did was develop little sections. And instead of just all over the place, what I've done is looked at nutrition and then types of children, and then diagnoses. So I made it a little bit more understandable. So, nutrition. When we think of nutrition, we know, and my class knows, I say nutrition, nutrition, nutrition. Without nutrition, an infant's not going to gain weight. There'll be failure to thrive. They're not getting fuel for the brain. And guess what's going to happen? They're going to be cognitive developmental delays. Why do you think, and there's many different reasons, but one of them is, why do you think we weigh a child height and weight every visit, whether it's to a doctor's office, to an ER, or to an urgent care?
For growth
We're
and
seeing that they're
development.
growing, right? Now, what if it's less than it should be? We're going to see developmentally, are they at 6 months turning completely over? And if they're not, we know nutrition could be the cause of it. And what would we do? Well, we teach our parents how to feed the baby better. Maybe it's reflux, right? We're losing all of that food in reflux. So remember, like for instance, if you have IBS, irritable bowel syndrome, or you have reflux, the problem is IBS food's going straight through. Nutrition doesn't have ability to be absorbed. So it's something that if we know a child has it, we're going to really pay attention to nutrition and making sure what they're not getting, how can we do it without hurting their belly, right? Causing those pains and those flares and cramping and diarrhea. Now, infant, we think those little spit ups are harmless. But when we look at that, don't we say that that little spit up is a little, but how much do infants really eat? Initially, it's only 2 ounces. So if 10 mLs come out and is spit up, they're losing a lot of their nutrition. So, what do we do for an infant with GERD just initially? Well, we give them actually from birth, if they need it, rice cereal. Rice cereal thickens it and it will hold it down. Sometimes with your breastfed, they'll say, take a little breast milk, mix it with rice cereal, give them a couple teaspoons, and then feed them on top of it. And they're not going to lose their food. Making sense here, doesn't it? How do we keep nutrition where it should be? Now, then as we're talking nutrition, we got to think about what's the diagnosis. What do we need to worry about? Well, if you had osteomyelitis and you're in bed, because one of the ways that we treat it is those IV antibiotics and then rest. We don't want to move that joint and create more irritation. But we need that bone to heal. So we know that we're going to do good protein. Protein is good, and all of those calcium, vitamin Ds. And here we are, fruits, vegetables, whole grains, low fat dairy, because you don't want too much fat. You don't want too much carbohydrates because they're on bed rest. You don't want this child to get too pudgy, right? Then you're carrying more weight. We don't want that. And of course, lean meats and fish. So that's how we're putting these nutritions together. Now, you have a child, any child. This one says obesity. If you have a kid who is overweight, or underweight even. How do you determine if they're eating properly? Parents think they're eating okay. Well, if the kid's old enough, let him write down everything they eat. At least, you know what they call it, the 24-hour food diary, 3-day diary, whatever you think will give you that best snapshot of what they're eating. It could be they're not eating the right things, right? And then we can make some changes. Now, you're not going to take all the way the good foods. I mean, it's not going to happen in a school age. You need to let them have a cheat, but remember that cheat maybe one time, and maybe there's other stuff they could cheat with that tastes better than it used to when I was a kid. Because I know low sugar stuff when I was a child, like low sugar ice cream, because ice cream would be my cheat. It was horrible. Today there are some that are quite amazing. Another thing we'll look at is the kid, is he up and is he moving? Or is this a kid that goes home and is playing on his, Nintendo Switch or on the computer? They're not moving. And do they have PE in school? And then as a parent, letting them know they need to get up and out and move and maybe putting them in a sport, something, something, something. So nutrition. What else are we looking for? I mean, nutrition is so important. You can see this. So if you have a child who has celiac disease, gluten intolerance, you are putting that breakfast tray on their bedside stand for them to eat. If you see something like crackers, get it off there. Don't give it to them, right? If they eat crackers, it's part of the wheat, rye, barley, and oats. They can't have it. And if they eat it, oh, they're going to suffer. It's really quite an intense abdominal pain that they get. Another thing is little infants. They get this ongo, as the Spanish population here in Miami say, or we get that yeast on that tongue, right? What do we do with it? Well, many parents think it's just the milk that's sitting there that can't be removed. So they try to scrape it off. Well, it can't be removed. So what do we treat it? It's a fungus. We're going to be treating it with nystatin. And they put a little squirt, swab with it, and they swab it in the mouth. An older child might swish and swallow, but infant put it on a Q-tip and then swish it around the mouth.
Professor Belgard, did you say for celiac, they needed to avoid the wheat, rye, barley, and oats?
Yes, it's the 4 type. And the one thing you can give is rice. Today they have rice bread, rice things that they use. So there is an alternative. Years ago, they didn't have it. So, as a nurse who's been around almost 50 years as a nurse, believe it or not, since 1976, I've watched them, people with celiac couldn't eat any because they didn't make those alternative, like rice flour. Rice is a great alternative. They can't have it. The other breads. I mean, can you imagine a toddler with no macaroni and cheese and chicken nuggets? I mean, that's like the mainstay. I hear it all the time. Okay, diaper
Professor,
rash.
the white patches in the
Gabrielle.
tongue.
Yeah.
Sorry, the white
Okay.
patches in the tongue, is that like thrush?
It is thrush. It's ungol. It's
Thrush.
thrush.
Mhm.
Yes, absolutely. That's the other name for it.
And so the thrush and the diaper rash is the reaction from if they have like
No,
the
no,
oh
no. These are separate little
oh okay
items. I'm
okay
mentioning that it looks like it's from nutrition because it looks like milk sitting there, but it can't come off. And it can't comes off. Nothing you do, scraping it off, it's not coming off. You need to give them the nice statin and with a swab, like I told you.
okay. So the white patches on the tongue and the diaper rash are unrelated to celiac.
Exactly.
Okay, just wanted to clarify.
It's
Thank you.
it's related to nutrition, okay? But thank you, Gabrielle. Somebody else might have thought that. All right, diaper rash. Diaper rash can be related to food going in. It could be that sign they're not tolerating a food. You say, all right, at 6 months, we start introducing solid foods, right? One at a time, 4 to 7 days in between giving them a new one. Now, it could be a light rash, it could be vomiting, diarrhea, abdominal pain, or a simple diaper rash. Could be what you see with the allergic reaction. We know if a kid's not sleeping at night, and the parents are complaining, I'll say, so does your baby have a diaper rash? Because that is probably the number one thing that lets the older ones, they can't rest. So diaper rash, they're not sleeping at night because as soon as they urinate stool, it burns and they're going to be crying. Okay, now let's get into infants. All different things about infants. Well, if you were looking at a newborn infant, one of the things in the newborn ICU do for your morning or evening assessment is to do a head circumference. We really are watching to making sure it's about the same, maybe growing slightly because the baby's growing. Now, if it's getting too much too quickly, what is the next thing as a nurse you would look at that can prove maybe it's hydrocephalus? The fontanelles. Fontanelles tell you so much on an infant. It can tell you hydrocephalus growing, or it could just be that hydrocephalus, or it could be if they're dehydrated, it's going to be sunken in. All right. Or you're going to see it bounding up, which would be your hydrocephalus. So looking at the head, there's something. First thing, look at the fontanelle. Remember any infant who is growing and maybe they can't eat. I always take the two things, tracheoesophageal fistula or esophageal atresia. That means food's not going down in the stomach. Food's going down the esophagus, across the fistula, into the lungs, or it's in this pouch of the esophagus. Nowhere to go. There's no connection and it comes up and we're going to have aspirations. So even their mucus causes these mini aspirations, right? This is a child. Make sure you give them a pacifier. How do infants self-soothe themselves? How do they
Sucking,
explore the world? In their mouth.
sucking.
Absolutely. Sucking. I mean, some kids like the finger, but that pacifier is so important to them. Now, I've gone through so many, they're good for them, they're not good for them. And that we finally realized that children, infants, do have a way to self soothe. Why are you taking it away from them? Give them the pacifier. Another question parents come in to is you've got a new, let's say an 8-month-old little infant, right? And they have an older brother who's 2. And mom's like, my, younger kid was already standing up and almost walking at 8 months. And what's going on? There's something wrong with my child, the newer one, the 8-month-old. And you take the child and sit them up because 8 months they should sit unsupported. And they sit there, they're unsupported. Guess what? There's absolutely every child is different. Some children at 9 months are walking. I've said to my classes, my children and my grandson that I talk about a lot never walked at 12 months. They all ran at 15 months. There was 36 steps with my grandson. There was, I think, 76 was the steps that my friend who was watching my um, firstborn said. So they never walked, they ran. Okay. Now, failure to thrive, FTT. Failure to thrive means they're small for age. Now, infants only can drink a certain amount of food. Failure to thrive could be because of a congenital heart defect. Their heart's burning calories, right? They need more calories to gain weight, not to just maintain, to gain weight. So there is formula off the shelf, which is 20 calories per ounce. That's your Enfamil, Isomil, whichever one. They're all 20 calories per ounce. You know, we have them up to 30 calories per ounce. So we can, give that much more calories in that volume because we don't want to overfeed, right? Because overfeeding leads to all other problems. Now toddlers, I call them my dive bomb kids. I love toddlers. I love the way they explore the world. All about me, mine, I do, right? Well, it's sometimes extremely difficult to talk with a toddler, ages 1 to 3. Especially, I worked the last 10 years in an ER. So I was getting kids in and out. I could do 40 children in a 12-hour shift that were assigned to my area. That's how busy it can be. So I needed to find a method. How am I going to get on their level quick? So they start trusting me and then teach them what I needed to. They're going to go for an x-ray, if they're going to go for an ultrasound, or what if we had to start an IV, right? I, number one, had to get on their level. That's always number one. I would never sit above them. I'd always sit below them. That always helped. And I always had stickers in my pockets. I had SpongeBob, Spider-Man, and princesses for the girls. And let me tell you, that, of course, works. Now, if a child is going for something more involved, um, there is a way that we can use dolls, stuffed animals, and show them the equipment in a very non-threatening way. So they can see where they're going to be touched, what's going to happen. A child, I'm telling you, little toddlers, ages 1 to 3, want to know what's coming, and they know more than you think they do. Now, preschoolers, we know that there's, fine motor, gross motors are increasing, but their speech at ages 3 to 6, preschoolers at the beginning, they're speaking at least 4 or more word sentences. They're more understood. That's what we do expect, the minimum we expect. Now, autism. Autism, we don't even try to diagnose to at least age 2. Um, Autism, you'll see the child, number one, decrease fine and gross motor skills. We know that. They don't like eye contact. They don't respond to their names, all of these things, and these repetitive behaviors. I've actually watched some children when I was doing clinicals for the Fortis here, how they would take this little autistic boy, he was 5, would take a fire truck and he'd like to put it on a stool or put it on a chair. Then he would take a doll and put it on top. Then he would take a block and put it on top and take something else and put it on top. And then in sequence would take the other thing off, the block off, the doll off, the truck and put it down and start again. Truck up, doll up, block up, repetitively. And they could do it 10, 20 times. And that gives them comfort. The other thing we have is this ages and stages questionnaire. It's at 24 months, and we can start to figure out, are they fitting into that autistic mode? So knowing that there is a questionnaire is something important for you to know. Now, school age children. These children, again, we are always doing height and weight. And we start to see resemblance to families. at this age. So sometimes some kids are tall, and sometimes children, the family is all small, they're all short. So before we assume that it is maybe a nutrition problem, right? If you're not having the normal height and weight, you would think nutrition. Ask, I see mommy is short. Is daddy also short? Or I see you're short. Is daddy, tall? Well, so you get a picture because it could be absolutely normal. So, but it is because of height and weight we're looking, and we know they're more looking like what they're going to be as adults from the family. Another thing that's really sensitive to children is if they go and they be hospitalized, especially for a period of time, remember the brothers and sisters, siblings at home. I would send like bows that I would make for little girls. I'd send one to their sister. Or we had little crayon books and little crayons, and I'd send them home with them to color all about hospitals. Or I would have the child, if they're able to, draw their brothers or sister a card. I'm telling you, those little things do save a lot of stress because the child in the hospital is stressed because they can't talk to brothers and sisters. I mean, we're luckier today because of FaceTime, but those little touch things that they could touch and look at really help.
Professor
Now,
Bogert,
yes.
about the siblings of hospitalized children, I
Mhm.
was noticing that HESI questions in a practice assignment. I couldn't figure out what to pick out of the question choices, and I don't remember any of them, or not all of them, but I end up picking up to a siblings to visit the illness child, and I wasn't sure about that. And
Absolutely. Now, remember, we just went through COVID. Nobody could visit. So
right,
then nurses had to step up and say, well, how can we take care of those siblings? And sometimes parent schedules, they can't get the kids in there. They're lucky they're in there. Or maybe there's an infectious thing going on.
right.
So yeah, absolutely, if they can visit for sure, but always prep that child. If they're intubated with tubes hanging out, with alarms going, they must be prepped for that so they don't, get there and just, get really scared.
And of course, the as long as the child is not isolated, it should be fine, right, with the standard precautions.
Usually, and as long as the kid is not sick too. And, children are always with a sniffle, so we don't want to bring anything in. There's strict guidelines, especially if they're going to visit them if they're in intensive care. It's
Mm,
a checklist that has to be done in
Thank
most
you.
pediatric places. No problem. So a kid's going in for surgery, say a TNA and adenoids, right? Tonsils and adenoids, big things, and tubes. Now, we think that children go in and the ones that have been there a lot don't really have as much stress as children who've never been to a hospital before. You should never assume that. What happened the other hospitalizations? Sometimes you have a child who is going in for surgery and they've had, some sort of hospitalization before and something bad happened. So always find out if we are teaching them because they're going for surgery. There's going to be some teaching that we do when they come in for, that pre-registration check and all of that whatnot. Make sure that we know, is anything ever happened in the past? Try to find out if it was and try to help that child work through it because a child who's not stressed is a lot better. Adolescents, adolescents are going through that time where they're growing real quick in the pre-adolescent, that 10 to 12 age, and they're growing. They're also getting into who am I? What am I, gonna be? Do I like girls? Do I like boys? Do I like music people, art people, band people? What do I like? Right? They're trying to fit in somewhere. It is really difficult sometimes to communicate with them, okay? So adolescents really prefer their buddies in them, as I call it, your buddies in them, not mom and dad. They just feel they can talk to them easier. And of course, mom and dad's always trying to put these rules down. So if we can, children, that have that ability to have visitors, try to schedule some time where their friends can come in and they can have alone time, if possible. It's important to the mentation of the child who's in the hospital. Now, teenage stages of development, boys and girls are different. We know girls start, with the breast buds get bigger. That's what they get. And we know males is the scrotum enlarges. They will, and I've seen a Tanner's question on one of the HESIs, and they wanted to know what stage it was. 1, 2, 3, 4, 5. So if we know we start with breast buds and then we go to mature, the in between we can figure it out just like males. So review that, okay? So that you know that for a Tanner question.
So
Yes.
stage 1 would be pre-adolescent.
Yeah,
There's
they
nothing
just
different there.
right, they're there. And then they start with the breast buds, and then the areolar enlarges, and then it separates contours, and then we become, a female, the full grown. And with the male also, and also there's heights and hair and stuff that go on, but knowing the breast bud and testicular enlargements are those two big ones. And then we can look at, the differences that changes. You can tell, is that in the beginning of this or at the end? And that's how I actually remember it myself. We start here and ends here. Where in the middle could that be? And usually you'll be pretty spot on. And they don't usually, it's middle, it's usually beginning or end stages type thing. Now, adolescents want some oral contraceptives. Now, what do you do? Well, if they're asking you, you don't have to tell the parents about it. Because many times, if we are going to interview an adolescent and we want to know what's going on, we'll ask the parents to leave the room. And the only time we need to tell the parents of what's going on is if they'll danger for themselves or others, right? So, what you do if they want information. Forget what you believe. You're not going to tell them not to do it. They're asking for oral contraceptives. They are going to be having sex. It's not going to stop. So give them information orally and written, okay? The benefits and risks, not your opinion, okay? Now, Piaget, good old Piaget, right? Remember, it starts out object permanence. That means that you have something there. And we usually do it like on their tummy time, right? As infants, we'll put that little what they want behind something and try to get them to wiggle to get there. Because they know, even if it's hidden, a toy, whatever, they still know it's still there and they're going to go searching. They're getting smarter. Erickson, infant, school age, adolescent, just what I told you, right? The three things. Infant knows if they're crying, somebody's going to come get them and whatever they need, their diaper changed, they're hungry, or they just want to be held, their needs are met because mommy or grandma comes get some, right? School age children. Now, the thing I describe about school age children is many of them go to the hospital extended time, right? For whatever reason it is. Now, they're going to be in this room, they're going to be bored, right? And you need to do something to occupy their time instead of just TV, right? TV they can watch at home. Um, I'm sure even their schoolwork is there, but if we did something to help them distract them from their illness and to give them something to do. I describe it as a school age child. Of course, it depends on the age. 6 to 12 is a long period of time. But if they're a 7-year-old and they're there for, a month in the hospital, I would ask this group called Child Life, do you have any puzzles? And I wouldn't pick the 1,000-piece puzzle. I would pick maybe the 50 or 100-piece, depending on the size, something smaller that might challenge the child, but they have the ability to finish it because it's industry versus inferiority. Industry is the industry they can build, they can do it, right? It's difficult, but they get there. Inferiority, they can't. And you do not want to do that. You want to give them an accomplishment. they feel good about it. And then health-wise, they feel better. So those are things that you will see with school age on that question. Again, the adolescent, we know it's all about themselves, body image. Again, talking to them very closely about sensitive subjects, have the parents leave the room. And again, you still got to build up to that adolescent. I always like they have a music in their ear. I'm like, so who are you listening to? Who do you like? Or if I see that they've got, they look like the child who's going to go to college. So have you picked a college yet? Depending on the age of them, trying to break their ice. Or, wow, I love your sneakers. Where'd you find them? I've been looking for them for my kid, grandkid, whatever, right? Those things, all of a sudden now the adolescent, oh, she's pretty cool. All right. And then they'll talk to you.
That's true. I have 3 adolescents, Professor, and they're all boys, and they always have their AirPod in the ear. Sometimes to get their attention just a little more, I ask them, oh, I would like to know what kind of music they're listening to. And they listen.
Yep. And I like all sorts of music. So I might even know what they're listening to, which
Right.
we're like, oh, how does this woman know that? Okay, hematology, all about blood. Well, let's talk about that child who's been diagnosed with hemophilia. Toddlers, remember, dive bomb kids. There's just no filter on them. They don't think before they act. So keep the home safe. Um, if that dining room table is at the height where they can bop their head, I would pat it or maybe prop it taller or get it lower because you don't want them bumping things. I think the coffee tables, sharp edges are a big one. So, or maybe in the bed, if they fall out, making sure that we inspect that home for all of those sharp areas, try to keep them from running. We know it ain't going to happen, but if we try, because they get cut, they're going to bleed, it's going to bruise, and then what do? Well, hemophilia child falls down, is outside, bumped his knee. He's got, this big ecchymotic area, and he's got this abrasion, which is now bleeding. So remember rice. Rest, ice, contain, elevate. That'll be always, right? And probably give some home factors. I've seen parents give home factors in the hospital because they came in for it and didn't know if they should. And our physician said, yeah, give it. I watched a father do it and he was amazing. And the son, actually, the kid who came in, was even picking out what vein for the daddy to use. He washed his hands, he set it up, pulled it up, gave it proper. I was amazed. Anyway, so home therapy is done all the time because with hemophilia, we need to prevent any sort of joint damage, and blood is caustic to the joint sac. Nosebleed, thumb, forefinger, pinch it and bend forward. Hold it for 10 minutes. If after 10 minutes it's still bleeding, they need to seek medical attention. And this is for any nosebleed because maybe they have that ITP, idiopathic thrombocytopenia purpura, right? Maybe they have that. And that sometimes is how we find it out through a nosebleed. So get them to some sort of medical care. Platelet counts low. Well, ITP, idiopathic thrombocytopenia purpura. It could be due to that. And in that, we are going to put these children on bleeding precautions. What are bleeding precautions? Well, soft toothbrushes, no razors. Sorry, the adolescent girl has to have hairy legs. You're not giving them a razor in the hospital because they will ask, trust me. No IM injections. We don't want all IV if we can. Monitor that CBC, seeing where those platelets go, right? And for ITP, what do? We give IVIG, right? And hopefully it will turn around. Maybe steroids, but most likely IVIG. All right, sickle cell disease. So you have a child who is sickle cell. We know sickle cell is when the vessels get tiny and then these little sickle cells
Professor,
get
I have a
stuck.
question.
Yes.
He was going kind of fast. You said give the IV the immunoglobulin
Yes.
for what? What were you saying? Give it for?
ITP. When your platelets are low.
Okay. All right. Thank
Okay.
you.
You know, on that case, any kid, any child with low platelets, you're going to actually see leukemia. A lot of times will have low platelets. Again, even if it's not ITP, platelets are low. Your nursing action is always bleeding precautions. Okay. Sickle cell, as I said, is usually due to dehydration. Vessels get tiny. Those cells, as it's going through these bifurcations, get stuck, and then they back up on each other, and it swells and it causes pain and it's miserable. So, what are some things we can teach to help prevent that? Well, always keep these children hydrated. If they're out playing sports, they better have a bottle of something next to them, right? Water, Gatorade, Powerade, something. They need to drink, drink, drink. And if they are in cold weather, again, that constricts, right? Vasoconstriction with cold. Keep them warm, dress them warm. It's one of the things they don't think about, believe it or not, is that just keeping them warm can keep the vessels open and prevent some sort of crisis. So ALL is acute lymphocytic leukemia. We know this is the white cells are immature, which means no white cells, you have no immune system. Always remember hand washing whenever you see anything immunosuppressed. And again, preventing infections, which again is good aseptic care whenever you can. And again, gloves and hand washings. These children will go in a private room because just because two kids have leukemia don't mean that they have the same germs, right? We don't do that. Iron deficient anemia, well, we know it's not enough iron in the body, and we can change the diet for sure. But many times we will put these children on a iron supplement. A lot of time it is liquid because the iron pills are actually big. Any of you been pregnant, see those iron pills? They're usually pretty big pills. So mostly liquid. What do we need to know about taking iron that's a liquid? Well, through a straw, preventing the teeth from getting darkened and discolored. Also, iron is broken apart and made available to the body by the stomach acid. So they say drink orange juice with it too, because again, another acid. No milk on an empty stomach. We want those stomach acids to work. JIA, juvenile idiopathic arthritis. So it is a difficult, in orthopedics here. So in children, especially if they have some condition that's going to require a lifelong journey of being a compliant, right? Again, children need to know that they're doing good. As a nurse, I would always compliment them. I would always do something special, whether it is get Child Life there to get them a toy or whatever it is, just to make them feel like they done something good. They take their medicines every day, or they check their blood sugars every day, could be part of it, right? But in anything. So you have a kid, fell off the monkey bars. What's the first thing you're going to look for? What is your first assessment? It's all about neurovascular signs, right? If you broke a bone, possibly that blood vessel could be compromised, kinked, and blood's not, let's say it's the arm, the fingers, you don't get blood there. And we know that neurovascular signs are the first thing we're going to do. And we're going to put a splint on it to get it to wherever they need to go. If we were out in a playground, right? So checking capillary refill and get a splint on the arm so we don't move it and get them there. Now, with JIA, one of the things is morning stiffness. Also, it's stiffness when you are sit for a while, try to get up. It's just part of this never ending thing. I mean, I have rheumatoid arthritis, so I know what I'm talking about. When you sit too long, get up, it's like, oh, all right, let me start moving. Now, children are very resilient, so you need to get them moving. Now, it hurts sometimes to run around, ride a bike. A pool, you feel weightless. I go swimming as many days as I can. My pool is ready to go right now. I was in last week. So outside. Remember, I live in South Florida. But a swimming pool, what do? Kids, they teach them to swim and they moving their muscles and it helps keep those joints moving because if you don't, they'll stiffen and then you're not going to get them unstiffened, right? So a swimming pool is a great thing. Some kids like to do, aerobics, ballet, whatever it is, as long as they're moving is good. Now, Harrington rods are put in for that S-shaped scoliosis, right? And that's when you have those percentages greater than, let's say, 50%, okay? It's way up there. So post-operatively, they've got this steel rod, and it's connected to either side of their spine. And one of the things we need to remember, you can't move them crooked because one of those attachments could break off and they're attached to those little prominences on those spinal cord. So you're actually cracking a piece of that bone in the spinal cord, on the whole back. So log rolling, very important. And it's holding the shoulder and the hips going together. And these are pre-adolescents. I'm going to have another person with me, making sure we get it over at one time. Now, children who get osteomyelitis, and one of the things that helps us in the treatment is to find out, has this kid really been sick a lot lately? Because sometimes that will affect the treatment of osteomyelitis. So it is a question that you should remember to ask. Has the kid had a lot of recent, infections? Cardiac, yours and mine favorite group, right? I think cardiac, especially because it's completely different than the adult world, it's really difficult to understand. Now, Kawasaki disease, red eyes, strawberry tongue, cracked lips, cracked blistered palms and soles of the feet, fever that nobody can figure out what's going on. So what our concern with Kawasaki is, it's a systemic vascularitis, which means the blood vessels are inflamed. And what we're concerned about is the coronary arteries. They can get an aneurysm and it can blow, and you have an aneurysm on a coronary artery. It's like having a heart attack, and then the blood is going off in the thoracic cavity. We don't want that to happen. So what are we going to do? Priority. Priority is we're going to need to do an echocardiogram. We need to look at the heart, make sure that there's no aneurysm there, okay? That's number one priority. What medications? This is when we give aspirin. Why do we give aspirin? To prevent clots.
Blood clots.
Yes, to thin the blood, because there's little clots going on there, and we're trying to prevent that because it's a lot of it, coronary arteries is going to clot off and you have a heart attack, a kid. So, and then your IVIG. So do an echo, make sure the heart is going on, and then IVIG and aspirin. 3 medicines that you're going to have to know. One of them is prostaglandins and indomethacin and Synagist. Those 3 you're going to see. So let's do 2 of them now. Now, prostaglandins is something that mommy has and maintains fetal circulation while the baby's inside. When the baby comes out, mommy's hormone prostaglandins is stopped. So usually this fetal circulation, the patent ductus arteriosus, closes. Now, things like transposition of the great artery, we have, systemic and oxygenated blood, they're not mixing at all. So we need to put them on prostaglandins because it gives that little bit of oxygen to the body, and it does really great. These children, I mean, you can wait for a week to do surgery with just a little slow, continuous infusion of prostaglandins. One of the side effects is bradycardia. So, as a nurse, if we see the heart rate dropping, we might have to decrease the amount given because there is 0.1 per kilo, 0.05 per kilo. We can go lower, okay? Now, here we have the PDA. We don't need it. Many times these are premature infants. And what happens, you hear like a washing machine murmur in there with this PDA open. And medically, we can close it. And we close it with indomethacin. And it's actually like ibuprofen. It's an NSAID, but it's IV, okay? So we give it IV, usually 3 doses. And as you're giving it, I used to always listen to the heart to see if the murmur was decreasing. Because the murmur's decreasing, we know the medication's working. And then we don't have to do the surgical where we go in and we just staple the PDA and stop it from working. Now, in congenital heart disease, you know, tetralogy or hypoplast or any of these conditions, these children have a heart that's working harder than normal. And sometimes the heart gets tired, right? Because it's working so hard to get oxygen around. And we're going to see them deteriorating. Well, what would you see? Well, number one, you're going to see a kid who's tachycardic, they're tachypnic. You're going to see that, you know, their heart rates are elevated, right? We're going to see maybe fluid building up in their lungs. And when looking at these children, intake, output, daily weight, you're going to see more intake than output, and you're going to see them weight gain. And these children would be difficult to feed. They're getting oral, a bottle. These children are not going to get nutrition because they're tiring out quickly. So if I have a kid who's showing these symptoms and not eating well, I'm going to listen to their lungs, number one, knowing with a congenital heart defect, the lungs could be failing. You see that. Cardiac catheterization. We know if we are doing echo and we see there's something going on, these children are going for a cardiac catheterization. Nursing care is mostly when they come back. The first thing I always look for is that pressure dressing. Now, on a newborn infant, they take a big catheter and put it in the femoral artery and femoral vein. And when they're done with the procedure, they hold it tightly and they don't let blood flow, right? Now, once it's clotted off, they put a nice tight pressure dressing. Older kids might get a sandbag on there, but they've gone from cardiac cath room now back to your area. It could have jostled the clot that was holding, you know, that femoral artery and femoral vein, and now you're bleeding. They can bleed out in minutes, okay? Femoral artery, bleed out quickly. So greatest risk is bleeding, okay? Bed rest 24 hours, they can eat and drink. It's not a problem. And they need to keep that right leg straight, checking those neurovascular signs. And they might have decreased pulses, but as the first nurse, document what they feel like so that the next nurse knows it's slightly diminished. Digoxin, they love digoxin. What do you know about digoxin? Well, as adults, what do? We check heart rate, we check dig level if we have one, potassium level, right? Now, in children, you need to know what the heart rate is that's normal because you could say a newborn infant heart rate of 100. Well, that's okay for an adult. That's low for a newborn infant. So if they're receiving digoxin, it'd be something that I would look for. And in infants, sometimes if they're vomiting, even once, I'm not giving the digoxin. I'm calling the doctor and we're going to get a dig level drawn before I will give it. It is safer to be safe than to wait and then your dig level is too high. Rheumatic,
Professor,
yes.
can it be true that when vomiting can cause like low potassium levels as well?
Of course it can, because any fluid that comes out, yes. And we know potassium levels have to be normal. So yeah, we could do the electrolytes with it too. Yep. Thank you, Yvette. Good answer. I like that.
Thank you.
Rheumatic fever is one of those things that caused by a bacterial infection, a strep infection that wasn't treated completely. It's from a rash to the swollen joints, the sore throat, fever, general tiredness, right? And also chorea, that weird movements that they have. The worst thing is if it affects a valve on the heart, right? Mitral valve. So how do we treat rheumatic fever? Well, it's antibiotics. Antibiotics are given, and usually it's longer, 4 to 6 weeks, and everything will return to normal except the heart valve. Once it's damaged, it's going to need fixed.
That would be with the antibiotic doxycycline. Is it?
It could be. Could be one of them, yes. Penicillin. They use all different types on it. Urinary, all about your kidneys. So urinary tract infection, how you know do they have it? One of the big telltale signs, especially children who are already potty trained, if they, wet their bed at night and they haven't done that in a while, is something you'd look for, right? We know it has to do with urgency, frequency, maybe some redness down there, and then the smell. One of the things to help prevent it is just increase fluids, right? And teaching how to wipe front to back. Cryptorchidism. Now, cryptorchidism is when the testicles are one or both are up into the abdominal cavity. They haven't come back down. One of the things and ways that we should be looking at this is put them in a warm room. Men, if they're cold, their testicles suck up. It is just a normal response to cold. It keeps them warm, right? When it's cold, when it's warm, they'll drop normally. So that's the way we need to check a newborn infant. Another thing is, have you felt it before? So then it makes you look a little closer at it. You don't put any water or clean it, none of that stuff. We're just going to warm the room. Long-term antibiotics. Well, we've talked about things like osteomyelitis, longer term. One of the things with osteomyelitis is usually a staph infection. So vancomycin is usually one of the antibiotics that they use. Now, vancomycin is an aminoglucoside. Remember, these are those drugs that you need peak and trough levels from. And if they are not monitored closely, the two things that it can do really bad damage to is hearing, can lose your hearing, and your kidneys can be damaged. So if we are having a child on long term, there's two things I'm especially looking for is if they're hearing okay and how many wet diapers if they're young, or if they're older, if how many times a day are they urinating? Two important questions. Now, nephrotic syndrome has nothing to do with kidney failure. Let me say it again. Nephrotic syndrome, the kidneys work. They are not kidney failure. What it is the kidneys say, ugh, protein, yuck, I don't like you. And it takes the protein and spills it out in the urine. So protein from everywhere is lost through the urine. So when that happens, intravascularly, we have albumin, right? Well, albumin is protein. It's another name for it. And when you have that change in the dynamics of the fluid, hypotonic, hypertonic, fluid goes extracellularly. And that's where the edema comes from, right? A lot of times you see it around their eyes, sometimes tongue, cheeks, everywhere. So whenever you are looking at any sort of thing with kidneys, fluid, remember intake, output, daily weights are always some good responses to it. Now, if a kid is full of fluid and we need to get rid of it, many times they'll give IV albumin, which is literally putting protein back into the vessel. Then, when they're done, they'll usually put some Lasix, furosemide, to try to pull out extra fluid. Now, how would we know that worked? We're pulling, hopefully, fluid out of extracellular, putting it back into, the vessels, and then goes through the kidneys. Hopefully, you're going to see an increase in urinary output, and the edema is decreasing. Your daily weights are going to decrease. Okay? Very huge, huge concept there. Now, hypospadias, epispadias. It is when the urethra doesn't come out the tip, right? It comes out somewhere on the bottom, hypospadias, somewhere on the top, epispadias. It's anywhere there. Now, big concern. There is some cultures, the Jewish religion likes to do these brisks, right? They cannot touch the foreskin. For this child, they will be trying to put the tip on the back where it should be, the hole that empties their urine. And they try to do it before they're potty trained. Okay? They need the foreskin for a plastic closure. So this child, one of the things we need to tell the parent who wants to do this brisk that we cannot, and the reason why. Now, what they do is they fillet the penis right open, okay? And they make a lumen that connects the bladder to the tip of the penis, and they make this area. They put in a catheter there so that it can heal with its hole open, so now they can urinate out the right way. Now, what do you do with that catheter as a nurse? Nothing. Leave it alone. Keep it in the diaper so the end of the catheter, which is draining urine, doesn't drain urine all over your bed, and then you have to redo the bed and their clothes. Have it inside the diaper. Many times I'll put a bigger diaper on, in order to get that catheter in. You don't turn it, you don't clean it, you don't put ointment on it, you do nothing. Keep it inside the diaper. And then usually the surgeon will remove it somewhere between 1 to 2 weeks, anywhere in there. They'll be removing it. But we want to do that surgery, of course, before they're potty trained, because they don't understand why their urine's coming out the wrong direction. It's not like daddy, right? Or like their brother. Wilms tumor is that kidney tumor. The big thing with this one is that if we touch it, we puncture it, anything, it can cause metastasis to go into the peritoneal cavity. Leave it alone. And we do not do biopsies to confirm what it is. If we did, it would ooze cancer cells. So no touching the abdomen, do not touch it, do not manipulate it, and no biopsy done. Now, with chronic kidney disease, one of the things is the erythropoietin and making red blood cells, and the kidneys don't work the way they should. Well, think about that child, the young child, they're still growing, right? If we don't have enough, erythropoietin in there, we don't have calcium, vitamin D, bones could be shorter, mal-shaped, and you can have a crooked arm, a leg, a finger, or whatever. So osteodystrophy can happen if we don't try to correct and give erythropoietin, calcium, and vitamin D. Can you see why? That's all good for bone health. Glomerular nephritis, again, strep infection. Remember, this is like having all of a sudden a hypertensive crisis and all of a sudden you're retaining all the fluid. It is quite dangerous. And the way to treat it is to give antibiotics longer period of time. And it's usually reversible, but only if they got there quick enough. This is hypertension. You see that red-brown urine, foamy urine. weight gain and edema is some of the signs that you would see that brings them in to the doctor. Testicular pain. Oh, I mean, okay, your testicle hurts, so what? Well, no, it's an emergency. I have seen children that have had torsion. Their testicles twist, blood supply stops going to the testicle, and they could lose the testicle if they don't go in, do surgery, and unkink it quickly. Now, respiratory. They love respiratory, right? I don't care med surge, I don't care peds. Med surge is always the top of the list. So, epiglottitis, what is it? Well, that's when a piece of tissue, the epiglottis, covers the trachea when you swallow, right? And then you don't get any food or water or liquid into the lungs. Well, the epiglottis, all of a sudden by itself, gets big and swollen, usually due to croup that wasn't treated, and now air can't go in. So if it can't go in, it's inspiratory problems, right? Stridor. Now, epiglottitis, your biggest concern is airway. So what equipment is needed there? Well, you need a trach tray, a tracheostomy tray, and an intubation tray. Now, will the intubation tray work when that's covered? Probably not. That's why you have the trach tray also. You know, in my career, I've never had to do this. I've never had to perform an emergency trach on these kids, but they're scary. They're very scary. They're drooling. They talk like that. They're sitting forward, tripod. They are pale. They're getting confused, hypoxemia. And it's that drooling that you're hearing, you can figure it out what's going on. What do we do? A racemic epi aerosol right now while you start the IV to give steroids, et cetera, et cetera. Remember with asthma, one of the things we need to be concerned about is the child getting that meter dose inhaler just by squirting it in the air? One of the things is making sure the children have a spacer and showing the parents how to use it. It's pretty neat, you know? I mean, people can't walk and chew gum without falling down, right? So it's squirted. Even adults have an issue with it. And it's a mask that goes around with a plastic tube, and you stick the meter dose in the end. If it's the dose is 2 squirts, squirt it twice, hold it, breathe in and out 4 or 5 times. Guess what? It's good. Infants cry when you do it, the younger ones, but guess what? They're taking it in really good when they're crying, right? They're and they're really getting that medicine in. Croup children, we know croup. It's benign, usually a virus. Haemophilus influenza is what usually caused by, but it's a virus. One of the things is they come in, we treat them. Usually we give them either an IM or a PO type of steroid, Decadron, or sent home with, you know, their prednisolone, one of those things. But one of the teaching that you must tell them, because remember, croup can turn into epiglottitis, which is an emergency, right? So if all of a sudden they can't swallow, guess what's happening? It's swelling in there. Tell this parent if this happens, they need to get back immediately to the emergency room, you know? And one of the things that really makes it important that if they've had a racemic epi aerosol because of the blockage was that severe, these children that racemic epi's worn off, they need other, you know, stronger steroids, maybe IV steroids versus, you know, PO or even IM, okay? Especially if they've had that racemic epi. And that is epinephrine inhaled directly into that area that needs it, okay? So it does usually work well. Now, RSV, the other word for it is bronchiolitis. Same thing, different word. RSV bronchiolitis. It is a virus. It is normal for me and you, a common cold, but for infants, they're obligatory nose breathers, right? And if you fill that up with mucus, how are they going to suck, swallow, and breathe when they're trying to eat? So we need to suction their nose with saline, and get it ready. So before they eat, I always warn the parents not to suction too much because you overstimulate, okay? Now, if a child already has an issue like a congenital heart issue, if they have something like that, giving them a respiratory infection like that is too much. Their body can't handle it. So there is a monthly vaccine called Synagis, palzivimab. It's one of those mAbs. And these children will get it for the first year of life only, usually from winter to spring. And that's, in your northeast upper climates. South Florida, we're still like, when do we give it? Because the weather doesn't change as much, but it is about 8 months that they do give it. Another thing with RSV is these children must be put in their own room if we have no clue about their immunization status, because an upper respiratory could be pertussis, it could be something else. So never, ever, ever place a child, upper respiratory fever, into a room with another child unless you know immunization status. So in infants, if you see an infant who is their nose is moving in and out, that's called flaring. This is infants, young children. And then at the end of each breath, you hear uh, and even their body bobs with this sort of breathing. That child's about ready to code an arrest on you. That child needs treatment now. So I would put this kid in a high-level room, a trauma room, because they need aerosols starting right now on these kids in order to get their airway clear. Cystic fibrosis. Well, it's two things, right? It's lungs and it's small intestines. So we give aggressive chest physiotherapy. Keep that lung moving, right? Now, I've told my my students, if you licked an infant, a child with cystic fibrosis, you're going to taste salt like you never could imagine. They lose salt through their pores. Now, don't ever lick your kids. All right. You might tell a parent if you did, you would taste salt and they could do it, but you're not going to lick the kids. Anyway, if you're concerned, cystic fibrosis, we'll do a sweat chloride test that's measuring the salt on the skin, and you're going to see very high levels is the point. Now, another thing is their way that they take food in and have the ability to digest it and make it into a food the body can use. Well, they need these pancreatase enzymes, okay? They need it immediately before they eat. And you do it for snacks and you do it for food. The one thing about these enzymes, if you're using powders and you have to put it on a little food, make sure they rinse their mouth. They have the little balls of stuff. They're like extended release. They shouldn't be chewing those things. One of the things we forget is to increase the dose as they get bigger. It's one of the big things in children that they do forget.
Professor, is it because one of the complications can be pancreatic insufficiency?
Absolutely. That's all part of it. You have to give that enzyme back so that we can digest food. Absolutely. Very good. Albuterol. That's our rescue, right? Can't breathe. They need albuterol, Proventil. These are other names for it, but albuterol is your rescue for when a kid is difficulty breathing. So in GI, what are some things we need to look for, ask for, etc.? Well, if a kid has diarrhea, well, we know the treatment is to orally give them what they need if they're alert. And we know that we're going to give probably a probiotic, to help it. And it's feeding these kids that help. But we forget to look at their butts, right? Sometimes they've had so much diarrhea, it's really reddened. And even parents, especially an older kid, 6 or 7, they're more private, right? They want to go to bathroom alone. Well, you need to look at their butt. They might need some cream or ointment on there. So don't forget that. Abdominal pain, what do you need to know? Well, where is it? Is it the right lower quadrant or is it the umbilicus? Makes a difference in the type of care, right? Umbilicus could just be, a tummy ache, some gas in there. But right lower quadrant could be appendix. So is it surgery versus medical treatment, right? Now, sometimes we have to do abdominal surgery to children. For instance, how about that, when you have, let's see, what's the name of it again? The kidney tumor, Wilms tumor. I remembered. Wilms tumor, you have it. They have to go in now. Your kidneys are in the back, in your back of your, when they're laying down, they got to go through all of these intestines to get down there. One of the complications, and any sort of surgery, like intussusception, you have to remove a piece of intestines, any of those things. Remember to watch out for these children for bowel sounds and making sure that they're passing flatus and, maybe some stools, because very, very commonly paralytic ileus can occur. And a paralytic ileus is pain in the abdomen and it can cause nausea, vomiting, abdominal distension. But what caused it? It was touching all those intestines. Those intestines got angry, didn't want you to do that. So it created a paralytic ileus. So that was the reason. Now, pyloric stenosis, this is the olive, all right? This is projectile vomiting. This is your 3-week to 3-month-old. And I've always said that sweet spot, 7, 8 weeks old, is where I've seen most of these children that you see that come in with pyloric stenosis. The pyloric valve is thickened, fluid can't go down, so it fills up, and all of a sudden, I'm telling you, you can hold these infants up 10 foot away from a garbage can. You can aim it. It will hit the garbage can. I'm talking not just 2 feet. I'm talking projectile. That's how it is. And I've seen it many times. These kids are hungry, 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 hungry. These children, you just need to put NPO, get it, send them over to ultrasound, confirm it. They go to the OR. And the kids do well postoperatively. We feed them within 4 to 6 hours, clear liquids, and they go home within a day or two. They do great. Now, intussusception is when the intestines go into each other. One of the problems with it is if the parent waits too long to get them into the ER. Usually they don't, because this kid's screaming and yelling and legs are kicking and they're miserable and nothing you're doing is helping them. This child, if you've waited longer, you had to wait for dad to come home, this or whatever happens, it will swell and it will be hard to come apart. So these children, you need to start an IV, get fluid. So you give fluid, hydrate that intestines, and hopefully we can pop it back out through just an enema. But these kids can come to the point of being lethargic with foods, right? If you don't feed a kid all the time, you can have the kid have the intussusception and it will stick there and then they're not getting sugar. Kids don't like that at all. They love to get their sugar. GERD, as you get older. Now we talked about infants, right? Infants are that little spit up. We're going to put some rice cereal, right? Now, as they get older, you get the tray in, you looking at what they're gonna eat, what are some things that you wouldn't want there? Well, you gotta look at reflux. What is the easiest on the tummy? They don't like high fat, so French fries, hamburgers, yeah, no, milkshakes, those are not good things. Anything acidy, oranges, orange juice. I mean, you've got to look at the tray. What is the blandest thing here? I mean, it might be leaving a cookie there, but a cookie is not really a bad choice. They got to eat something sweet, right? Now, you get a kid. and they're getting jaundiced. Their sclera are yellow. Their urine is tea colored many of the times, and the stool has no color. This is called biliary atresia. And that means atresia without no connection between the liver to the common bile duct, which means no bile is getting to digest food, right? So that's why the stools are pale. Well, that jaundice, right? All of that, the bile can't go anywhere, so it goes in the body. And that's why the color changes. That's why your sclera turn yellow. And we're going to see that dark tea colored type of urine because that's a lot of your bile. Now, neuro, neuro is many different things. We can go from ears understanding why your ears are ringing up to seizures, myelomeningocele, are all different stuff. But you get an adolescent down as a school nurse, let's say, and they're complaining of ringing in their ears, or they come into the urgent care. I'm getting this ringing in my ears. I don't know. Well, what's the first thing you need to do? You need to just look in there. Is there something there? I've seen beetles, bees, crayons, lead things from pencils, all in ears. So that bee could be buzzing, right? Ringing. But the first thing you need to do is check the ears, all right? So make it simple. Meningitis. Well, meningitis could be viral or bacteria. How do you delineate? How do you separate? When do you know when to give antibiotics? Well, you're going to do a lumbar puncture, get that kid prepared. If it shows bacteria, it's going to be white and milky looking. Viral is going to be clear. And viral meningitis is treating it like a viral cold. It is acetaminophen, ibuprofen, and rest and liquids, just like a common cold. But in meningitis, that's bacterial, your priority is antibiotics. Remember with seizures, our big thing is safety. You need to keep those kids safe. One of the things is side rails up, right? If they're having a seizure and you walk into a room, turn them on their side in case they vomit. There's toys in the bed, get rid of them. And try, if you can, with the side rails up, pat them with their pillows or blankets or something, because they will bang them when they're in this tonic-clonic, okay? Febrile seizures. We know this is 6 months to 6 years, and then they usually will grow out of them. Sometimes it's one time, and sometimes it's more than that. Your parents, the first thing they're going to ask, does this mean my kid has epilepsy? Well, a febrile seizure is not considered epilepsy. And we know that epilepsy is unprovoked. That means there wasn't a fever that started it. And it's usually more than one a day you might see with them. A myelomeningocele is that blob on the back of this poor little infant's back. Our biggest concern is they have, this blob has the meningeal sac, and it's the spinal cord, and it rips the nerves as it comes up, pulls it up and out. So nerves on the lower part of the extremities are decreased, or they're not feeling anything, any level of. Our biggest concern is urinary retention, making sure that we monitor our urine output. They're going to be getting frequent urinary catheterizations, usually every 4 hours, right? To get rid of their urine. And these kids immediately are put on latex allergies. Neuro. Well, Duchenne muscular dystrophy. As I said, Duchenne muscular dystrophy is seen on HESI, it's seen on your NCLEX. Now, Duchenne is a condition of boys ages about 3 to 7. You'll see what's going on. And these children have progressive muscle loss. One of the ways that they start to diagnose these children is you're talking about muscles and usage, it gets weak. We do something called an EMG, electromyogram. And what they do is they put a patch or sometimes needles into the skin, and then they put an electrical shock, and they see how long did it take for the muscle to respond. One of the things you need to remember if you have a child going for this, when they come back, it's like they've ran a marathon. You have stimulated all their muscles and they're going to hurt. Give them some Tylenol or give them some ibuprofen and let the parents know. Sometimes give it before they go. So when they're there, because it's not going to interfere with the exam, and they'll already have it on board when they start to feel like I ran a marathon, okay? Duchenne muscular dystrophy is, the muscles stop working. This kid, they are cognitively delayed. That's one thing. Now, most of them could be up and walking, and then all of a sudden they look like they're going backwards. They're starting to falling down. They start waddling gait. You'll have big hypertrophic calves and upper arms. Those muscles tend to get big, and it comes from mommy. This is the X gene recessive. These children usually die as adolescents from cardiac and respiratory failure, both a muscle, right? Eye injuries. What do you do? Well, when you have a kid who scratched their eye or something is in there, rubbed by a pine cone, whatever, fell down, they say patch both eyes with a fox shield. And all that is a hard. It keeps it from pushing against. The eyes, it's a hard thing called a fox, like FOX, like a fox. Fox shield, get them either to the ER or to a pediatric ophthalmologist. Nystagmus is when your eyes don't fixate on a point well. So what we'll do is an eye exam, the 6 cardinal positions of gaze. Now you wonder why in health assessment you learn these things, right? Hydrocephalus, well, we've talked about it. We know it's too much fluid. One of the things that they can look for besides that increased head circumference and then that fontanelle that's big is they might have to put in a ventricular peritoneal shunt. Sometimes it's all, the way the body was formed, it didn't form right and the drainage isn't correct. So they have to do something for the body, or else it would just get bigger and bigger in the head with all of this extra fluid. So we put a VP shunt in. Now, one of the things that I have seen so many times, because kids grow. I mean, that's what kids do. So sometimes they disconnect. And these kids will come in with increasing pressure. What do you have? Symptoms that you would see: headache, vomiting. And if you know they have a shunt, that kid is an emergency. They'll get over for a shunt series in the ER, into the x-ray department, and then most likely they'll be heading up to the OR for either a replacement. Maybe they need a bigger shunt. They've gotten bigger, right? Or they just need it connected. And remember that it comes through the fourth ventricle. Behind the ear, there's a tube, and it goes around the front of the chest into the abdomen. There is a little pump behind the ear here. Do not touch it, leave it alone. That's only for neurosurgeon, okay? Our care, measuring their head circumferences and abdominal circumferences. Those are the things that we'll do. Now, endocrine. Again, hyperpituitarism. This is, your other lobe, your anterior lobe of your pituitary gland. We know that it secretes growth hormone. Again, why do we do height and weight on all children? We're trying to find out, do they have hypo or hyperpituitarism? So height and weight clearly shows this. The parathyroid gland has nothing to do with the thyroid gland. The parathyroid gland is its own entity. It's not a thyroid that we look at. It's all about calcium regulation. So, what do you need to know about calcium? Well, calcium and magnesium have also all to do with muscle, the way it contracts and it works. So, not enough, the muscle's weak. Okay, makes sense? Muscles, calcium and magnesium both. Now, if you have a kid hyper, it's going to be in tetany. It's going to be so, stimulated. It's going to be just sitting there. Okay. So it goes from weakness to too much. Hyperparathyroidism, calcium. Diabetic ketoacidosis, some of these children, they say from age 6 up, depending on the smartness of the kid, can be put on a pump. They're great as long as they can monitor and adjust and give boluses and do their dex sticks is fine. These kids do very well. These kids can go out, they can play sports. In fact, we encourage that. Again, making sure they have snacks there as they're going and playing the sports. They don't go. And they should check their blood sugars before they start playing a game, just to know where they're starting. So, of course, with diabetes, if we are giving injections, of course, it's rotation of them. And here's all the places. What do you see with hypoglycemia? That is either nauseous, headaches, sweating, shaky. What do we do? Well, honey, be good for an older kid. Sugar, a lifesaver, glass of milk, glass of orange juice, something, give something now. Now, there was a question regarding breastfeeding infants, and it was about thyroid hormones and talking about T4 and TSH. Well, just know if TSH is high, T4 is low. And if T4 is high, opposite for TSH, it's low. Why? It was just one of those hormone questions that's what I saw. Now you have an adolescent and their BMI is high. It means they're big kids. And then let's say they come in and they're complaining of urinating a lot, frequency. Well, what do you suspect? Well, there's two things, right? If you are urinating a lot, what would you suspect? Well, maybe urinary tract infection, or maybe it's diabetes. So we'll be checking, their hemoglobin A1C, we'll be checking their urine, and of course, checking electrolytes, because of course, loss of potassium. Now, some common kid diseases. We don't really go all over a lot of these in class, so you get them right here, okay? Impetigo is a staph infection. My grandson had it on the back of his leg, and it got worse and worse. My daughter thought that he itched his legs from mosquito bites too much. And I looked at it and I go, oh, that's impetigo. So it is infectious, all right? It is staph. You should, and it looks like that face to the left. That's impetigo. Could be anywhere. And it needs oral and topical. That Bactroban ointment, that one that's not over the counter, it works good. And then they need orally. Usually it's that Keflex, cephalexin is what they'll take. Conjunctivitis, we know that in kids and adults, you put on an ointment in their eye and they can't see, they're going to freak out, aren't they? Always clean from the inside out. Put the ointment in and tell them when it melts, you'll be able to see well. Don't get alarmed. It's okay. It is normal. Ticks. Now, you have a kid who had a tick removed and now they're with a fever. What do you do next? Well, this is something that you need to get to your doctor, right? We need to find out if they have what? Lyme disease. Very difficult to diagnose many times. Remember tetanus, if they come in and they've stepped on the dirty nail is always that common thing. Always make sure what was their immunization status. Our treatment is to clean it. Water and soap and antibiotic ointment on it. And then we can always give a booster. with the for the tetanus. Chicken pox. One of the things you need to know is that if you see a rash with a fever and the rash is on different levels of healing, most likely that's chicken pox. And it's highly contagious. And it doesn't matter if you've had that immunization, okay? So chicken pox, you're going to see the rash 2 days prior to the rash until all of the lesions are crusted. This is when you're going to be infectious. Okay? So before you get the rash is usually when we spread it, right? Once they have the rash, most of the time, as long as they're crusted over, you're fine. Head lice. I mean, my poor kids had it 3 times. My daughter had thick hair down to her butt. And I had 3 times. I had to put lice treatment on her and wash everything in the house. I was doing laundry like crazy. And no, I did not cut her hair because it was just too cute. Anyway, inspect the hair follicles. You'll see it. Fine tooth comb and lice treatment will do with that. Otitis media, we know that if you breastfeed, you're going to have decreased occurrence because we know breastfeeding is giving body antibodies to that infant every time we feed them. One of the big things is avoiding smoke. Big thing on otitis media. ADHD, attention deficit hyperactivity. What we give is a stimulant, right? Adderall. One of the things that we need to do is give them a chart, give them consistency. They like routine and schedule, okay? And give them one place to do their homework. When they're sitting there, they know it's homework time. It can't be a place where they play games too, because these kids' mind will go to the game. So one place for that. We've already talked about nosebleeds. Remember, it's 10 minutes. If it's still going, please get to the doctor. Now, infectious disease. Remember, safety, infection control are big things, okay? So, low neutrophil counts. What's a neutrophil? Anybody know what a neutrophil is?
White blood cells.
It is a white blood cell. And what do white blood cells do? They fight infection. Okay, so if your neutrophil count is low, now let's give you a scenario because you'll see things. You'll have 4 different patients. Which one do you see first? A child that had a neutrophil count of less than 500 with a fever is your priority. They are about to go into septic shock. Every other person can wait. Can you see that? I have no infection, nothing to fight it. I am so immunosuppressed. And I have a fever. I'm in real trouble. I need IV antibiotics as quick as I can get them. That's your priority. Infection control, I always say hand washing, hand washing, hand washing. And then another thing is keeping the parents with the kid who's under, respiratory isolation in the room. They like to take, oh, well, my kid, can we get him in something to eat or a bottle? And I'm like, would you put the kid back in the room, please? They don't remember it. It's something that you have to remind them. And I tell them on admission, your child is under respiratory isolation. If you need something, you can come alone, but you cannot bring the child out of this room. Immunosuppressed child, first thing that we want to do is check a temperature, right? We want to see, do they have a fever? Also, any immunosuppressed child, sickle cell, rheumatoid arthritis, diabetes, they run a fever. Again, remember, they're all immunosuppressed. They have 100.5. They need to call their doctor. They need to be placed on an antibiotic immediately. It's one of those concepts that we miss all the time. Giving immunizations. Well, what do we do at 2, 4, and 6 months? What is it, 4 different injections we give? 2 in each thigh is a lot of immunizations, right? When they come out, it causes those thighs to be irritated, right? this vastus lataris area really gets miserable. So how do we help these parents take care of these children? Well, if they are under 6 months, give them some acetaminophen, Tylenol, okay? They're going to have a fever. It is not uncommon. It's the body's reaction to what you just put in there. It's making the antigens, okay? Another thing, putting a cool pack. I put like a cool washcloth or one of those cool packs with a piece of, blanket or something, not directly on the skin of the cool pack, but on a blanket. The other thing is pedal the legs. Like you take their knees up and down on their back, and that moves the muscle and it helps move around those injections you just gave and will decrease the amount of pain. MMR is given at 12 months. The second one is 4 to 6 years. Remember rheumatic fever, we know everything is going to be going fine once we start the treatment. The only thing that's left, as I said, is that mitral valve. And then there were four acid-base questions on the last exam I saw. So let's put some into perspective. Anxious, fearful, hyperventilating is respiratory alkalosis. Diarrhea is all your alkaline, which is all your enzymes for digestion. It means your intestines is all alkaline. You're having diarrhea, losing alkaline. What is left? Acidosis. Now, conversely, your stomach is full of what? Stomach acid. You're vomiting. Acid is going away like crazy. What are you left with? You're left with alkalosis. That's how you remember them. And then Kussmaul. Well, Kussmaul is with DKA, right? When you're metabolic acidosis. So remember this. If you have a condition like metabolic acidosis, your body is really cool. It says, what can I do to try to compensate? So if it's metabolic, it becomes respiratory. And if it's acidotic, it becomes alkalotic. So Kussmaul is respiratory alkalosis. It's those pushing off all the air, right? Kussmaul respirations, trying to compensate. So again, remember, read the question, go back, make sure you're answering what you're supposed to, because I know this is the most common mistake. I tell all my students to make sure they go back. Listen to this. You guys are going to do well. I really appreciate you coming. Anybody have any questions?
No, thank you so much, Professor. You did amazing.
It's my pleasure. Nice